And speaking of people just not having access to
Mm-hmm.
molecular testing, what advice would you give to community oncologists or general
Mm-hmm.
pathologists who may not have immediate access to advanced
Mm-hmm.
molecular testing?
I would say the field has really exploded over the years, and there are multiple companies. So you can connect with those companies. Many of them have really developed patient assistance programs. There are some clinical trials where you can use profiling as part of the clinical trial and have it covered. So there are different avenues. And I really think that it is our responsibility as physicians caring for these people to explore every avenue to ensure that everyone has access, under your domain, that they have every opportunity to have the best care possible.
One thing I did want to ask you, just now knowing that these are two separate studies, what are there any clinical implications of distinguishing between pediatric type and adult type diffuse gliomas,
Mm-hmm.
and did that impact your treatment plan at all?
It hasn't impacted treatment, but a lot of us in this field believe that there is a difference between them, and it may be based on location, it may be based on behavior of the tumor. One of the pieces missing in this puzzle is the ability to analyze other biomarkers. And so again, we need tissue, we need access to testing. And so some of the newer studies that have been designed that are open in the US do allow for more biomarker testing. So I think that in the next few years we'll see more to guide us.
What were the most exciting takeaways for you in conducting this study that you hope to kind of work on in the future and
Hmm.
maybe ultimately see implemented?
It I've had several patients over the years who have been treated with this medicine, and it truly is the day to day interactions with those patients. One patient who was able to live several years, to to be at home with her kids and to enjoy that time. Um, and when people come in and they say that, when we talk in the beginning, we talk about how average survival for this illness is around 1 year. And so when we're able to expand that into several years, and when patients are so grateful for that time and the quality as well, the quality of time really matters. It it is it is really life changing and career changing, and it will make you want to jump through the hoops and do what you have to do um, to make that available for them.
We have
Hmm.
these highly specialized things like your multi-letter
Yeah,
focus area, and we have conferences like ASCO. What
uh-huh.
we're finding is a lot of diseases multifactorial.
Absolutely.
It's
Hmm.
personalized medicine is like you have this genetic
Hmm.
mutation or this
Hmm.
epigenetic marker, and that
Hmm.
impacts how
Hmm.
your cancer, although the same as this other person, is going to react.
Yeah.
I don't see a lot of conversations across specialties. And I feel like that's where a lot of the real insights kind of exist. And also, you're a doctor. So who even has time, right? Even reading through the abstracts here is like so much.
It
And
is.
this is one thing,
It
right? But
is.
there's
Yeah.
so much insight.
Yes. Medicine is very
How?
siloed, and it's a problem.
Mm-hmm.
It's siloed from specialty to specialty, and also from academic physicians to community physicians. And so one of the things that some of the leaders in the fields in oncology, what we're trying to do, for example, is to break down some of those barriers, to bring in patient advocates, to bring in nurses, other, health professionals into these decision making groups. Um, in the world of oncology, a multidisciplinary tumor board is it's the secret ingredient. It really is, because you sit around the table virtually or in person with multiple specialists,
Mm-hmm.
and you're forced to talk about cases together. We also have nurse navigator model in oncology, and so your patient knows that they have someone. Their goal is to care for that patient and to cross disciplines through surgeons, through radiation, and so forth. And then lastly, one of my favorite things that I do is I work with two other physicians in a multidisciplinary clinic. It's a genetic predisposition clinic for patients who are at high risk of cancers. So as a medical oncologist and a neuro-oncologist, I serve that role. We have a geneticist and an endocrinologist. And so we'll see patients together. We'll look at their genomic markers. We'll look at their germline baseline testing, and then we'll decide how can we proactively look for cancers, and then we reach out to all those subspecialists.